Good evening. Sorry for the late problem. Tonight's session is going to be about MCQs, a little bit off track because I thought just going on with solid sessions for a long time might be boring. So let's interrupt that with some few interactive sessions like MCQs, and here we are. So what I meant by this session is definitely to be interactive. So you are the one who's going to be talking, and don't shy away from wrong answers. That's not the purpose here at all. MCQs are vehicle of pieces of information that we are going to deliver as we are going through this session. So the first question is, you have an image on the left and a question on the right. The structure shown by the star, and I hope you are seeing that star, is more resilient than the left atrium, less dependent on atrial contraction than the left atrium, always the shelter of clot in atrial fibrillation. It is 80% the shelter of clot in MS, routinely occluded during cardiac staging. So what do you think the right answer is? So this structure we are seeing is what?
The left atrial appendage.
Yeah, exactly. The left atrial appendage. Okay. And the image here is particularly showing a very large left atrial appendage, which houses a dense spontaneous contrast, right? There is dense spontaneous contrast, as you see, which is a precursor of thrombus formation. So, okay.
Sorry, Dr. Hatim, the sound it is not really clear. There is something wrong.
Not
with the
clear.
sound. Sorry.
A moment. I will go with. So, how is it now?
Yeah, it seemed to be better. Thank you, sir. Yes, thank you.
So how is the sound now? It's better?
Very much better, sir.
Very good. Sorry. So back to the question. So we said this structure is the left atrial appendage, and as it's shown in the image here, it's dilated with dense spontaneous contrast, and this dense spontaneous contrast is a precursor or a substrate of thrombus formation. Okay. So where are we here? Is it more resilient than the left atrium? Less dependent on atrial contraction than the left atrium? Always the shelter of clot in atrial fibrillation? 80% the shelter of clot in MS? Routinely occluded during cardiac failure? Any guess?
Always shelter of clot in atrial fibrillation.
I vote for the C answer.
For the C, yeah? Okay. Always, eh?
I'm going with the 80% is the shelter of clot in contents of MS.
Okay, 80%. Good. Okay. So that will bring us to statistics. In atrial fibrillation, the thrombus is formed in the LA appendage in 98%. So it can be found in the left atrium in like 2%. So that will negate always here. So it's not always. When we come to the MS, what do you think about MS? If a patient is having MS alone or MS with AF, now the censuses are going to change even more in favor of thrombus formation in the LA cavity, because the MS will disturb the entire LA cavity, not only the LA appendage. So in MS, it is 60% in the LA appendage and 40% can be found in the LA cavity. Okay. So that means C and D are not right. Okay. So we are left with 3 other options. Any guess?
I think C. Less dependent on atrial contractions than LA.
Less dependent. Okay. That will bring me here. Look at this one. This is the LA appendage, right? So the LA appendage is kind of an out pouching from the LA cavity on the anterolateral wall. So the LA appendage goes out of the cavity and rests on the LV to some extent at the atrioventricular junction. Okay, look at this flow signal. The most important of which is this, and I wish just try your best to focus on this. Okay, this one is the atrial contraction effect on the LA appendage flow, and this is the passive emptying of the LA appendage. So if you put them together, it looks like this is E and this is A. E, this is E, and this is A. Compare this with the normal mitral inflow. How does it look like? It looks like E and A, E and A, meaning in the mitral inflow, it's more dependent on the initial phase of passive filling than atrial contraction. While in the LA appendage, it depends more on the atrial contraction than the passive emptying. What does that mean? It means that the LA appendage evacuation is more dependent on the left atrial contraction than the LA cavity. What does that mean? It means that the LA appendage is more sensitive to atrial fibrillation than the LA cavity. What does that mean? It means that the thrombus forms in the LA cavity in AF in 98%. That's why. Okay. So did you get the point here? Yeah?
Yes.
So this is important. So the LA appendage is more dependent on the atrial contraction for evacuation than the LA, than the left atrium itself. And that's why it's more sensitive to losing the atrial contraction in AF than the left atrium. Good? So if we go back to the MCQs, less dependent on atrial contraction than the left atrium, it's more dependent on atrial contraction than the left atrium. So we are left with A and E. A and E.
So we can choose E, routinely occluded during the cardiac surgery.
But is it?
I think. I'm not sure.
Yeah, no. Initially, I think sometime in history, they used to occlude it routinely assuming that it's functionless structure. And once you are in there, and it's a source of source of trouble in the future, so let's just get rid of it. But now they are not doing that. They are occluding the LA appendix surgically for particular purposes and particular indications. So it's not routinely occluded in surgery. So the right answer here is that it's more resilient than the left atrium. And more resilient, when you take the histology, or you look at the histology of the LA appendage and compare it with the LA, you'll find more of elastic tissue in the LA appendage. It is more likely to dilate and expand if there is high LA pressure. So it's more resilient in the dilatation. And this is actually, people think that LA appendix is not what is considered to be functionless structure. It's an important venting structure. It vents the pressure. It takes the pressure away from the LA. Okay, so it's important. And occluding the LA appendix, whether percutaneously or surgically, might not be so wise. Now, it's an important structure for modulating the LA pressure. Okay, so this is as to the first question. Next, which one is true regarding the pulse? Pulsus alternans is called the death ratio. Electrical alternance leads to beat-to-beat variation of the pulse. Pulsus deficit occurs in VTAC. Pulsus paradoxus in tamponade is due to increased blood flow in the left atrium in inspiration. Collapsing pulse is invariably present in severe AR. And I don't think you have just to choose the right answer. If you think one is wrong, tell us that this is wrong and it's wrong because of that. So I'm not really interested in picking up the right answer. So if you think anyone is wrong, tell me which one and why.
I mentioned E, collapsing pulse is invariably present in severe AR. It's not just in severe AR.
Okay. It's not just in severe AR and not invariably in severe AR.
Yes.
Yani,
So
it's not always in severe AR. You can have severe AR with no collapsing pulse.
Yes.
Right? So
yes.
E is wrong. Right, you're right. What else?
Second thing, Dr. Hatim, number C, pulse deficit occurs in VTAC. This is what we know, it occurs in atrial fibrillation rather than in VTAC.
Exactly. And what is pulsus deficit? How can you explain it to us?
The difference of the heartbeats when you calculate by stethoscope in the heart and when you calculate the pulse peripheral in the radius.
Exactly.
So when the difference is more than 10, this is significant.
Exactly. So it's in AF, because in AF, when you put your stethoscope in the precordium, you might find a pulse rate which is faster than when you find in the pulse peripherally, because some of beats are too weak to be felt down there. Too weak to be felt down there. That's the pulsus deficit in AF. Okay, good. So now we eliminated 2. Anything else to eliminate? What about D? Pulsus paradoxus. Pulsus paradoxus in tamponade is decrease in the blood pressure during
inspiration.
Exactly, during inspiration. And why is that? Because the blood flow to the left ventricle decreases during inspiration. It decreases during inspiration in tamponade, and the septum shift even leftward, compromising the cavity even more. So there are 2 factors for why the blood pressure decreases during inspiration, because the flow from the pulmonary circulation decreases, and because the septum shifts leftward. Okay, so the pulsus paradoxus in tamponade due to increased blood flow is actually due to decreased blood flow in the left atrium in inspiration. It's decreased blood flow. Okay. Okay. So we eliminated 3. What about B?
Electrical alternance leads to beat variation of the pulse.
It's true.
True.
Electrical alternance lead to beat variation of the pulse. I found out, you know, this confusion is so common between pulsus alternance and electrical alternance.
ECG finding.
Thank you so much. The electrical alternance is ECG finding, not clinical sign. It's not a clinical sign. So you don't find anything clinically. By clinical exam, you will find nothing. Electrical alternance is beat-to-beat variation in the ECG only, but the pulse is fine. And usually it means that probably you have large fluid and the heart is swinging, and we know that, yes. So pulsus alternance is beat-to-beat variation in the pulse. That is wrong. Okay? It's beat-to-beat variation of the pulse or in ECG. It's beat-to-beat variation in ECG, not in the pulse. But pulsus alternance is beat-to-beat variation in the pulse. Okay? And this indicates what? Beat-to-beat variation in the pulse indicates what?
Cardiac tamponade.
The beat-to-beat variation in the pulse, not in ECG.
It means the LV function is poor.
Exactly. So the pulsus alternance, which is beat-to-beat variation in the pulse, and you put your finger in the radial pulse, and you are gonna feel that one beat is strong, one is weak, strong, weak, strong, weak, like that. That indicates severe LV systolic dysfunction. Severe. And that's why they call it death rattle, because it means that this is kind of terminal heart failure disease. But electrical alternance, if you put your pulse, your finger on the radial pulse, you are gonna feel the pulses normally, no changes. But when you do ECG, you are gonna see that there is voltage changes between beat and the other. And that indicates large myocardial effusion and the heart is swinging, meaning that the heart is coming closer and away from the chest. That's why the ECG leads are picking high electricity and low electricity, high and low. That's the reason. Okay. Okay. Which of the following is true about physiology, cardiac physiology, and pathophysiology? The diastolic function is a passive, energy-independent process. The atrial remodeling in AF leads to uniform dilatation in the 3 dimensions. The basal myocardium, in the basal myocardium resides the densest adrenergic receptors. The radial motion of the myocardium is the only motion responsible for the ejection. The function of the aortic trileaflet relies on the aortic root, recoil, and dynamics. Remind you, you don't have to choose the right answer. You can exclude the wrong answers. So
I will start by choosing the D answer. The radial motion of the myocardium is the only motion responsible for the ejection. It's wrong.
It's wrong. Good.
Yeah, it's
Why
not
wrong,
just a radial motion.
So
I think it's yes.
Do you know any name for any other motion that is responsible for the ejection?
we have radial transverse, I think. The three
Twisting motion.
motions, I think, twisting and radial and transverse and vertical. I'm just confused with a lot of motions.
Exactly. There are a lot of motions actually. The radial motion is the most one that we are accustomed to seeing and evaluating, because this is how we calculate the ejection fraction. Okay, and we thought that the heart just moved this way, in and out. The radial motion means the contraction in and out, in and out, the one we see in the short axis. But they knew now there are circumferential, there is longitudinal, there is twisting and untwisting motion of the heart. Okay, so you have to remember that there is circumferential, there is longitudinal, and there is twisting and twisting.
Twisting,
okay?
But the major is radial motion.
The major, the one we are evaluating. Yes. Okay. لكن الآن with the technology of the strain, we can evaluate the longitudinal motion, we can evaluate the circumferential motion, we can evaluate the twisting and untwisting of the heart. Like in previously, we only know how to evaluate the radial motion, but now with the strain, we can, and we actually are evaluating the longitudinal, circumferential, and twisting motion of the heart. يبقى D is wrong. What else?
Second thing, number A, the diastolic function is a passive, energy-independent process. Also, it is wrong. It is not passive process.
Okay. It's not passive. It's energy dependent.
Yes.
Okay, and you remember probably Dr. Bakra has shown that the diastolic function has a lot to do with calcium handling, intracellular calcium handling. So when the action potential comes in, it sweeps in the cell, calcium is released, and the calcium release will induce more of release, the process called calcium-induced calcium release. And this calcium comes from the sarcoplasmic reticulum, and it goes into the sarcomere and the T, I, and C troponin, and induces the contraction. So when the contraction finishes, that calcium has to be resequestered into the stores back again. It has to go back to the stores. If it doesn't go back to the store, the contraction will remain and the relaxation will be difficult. Okay. So what takes calcium back is energy-dependent process. Okay, energy-dependent process. Okay. So it is not passive.
Yes.
So now we eliminated 2.
Also eliminate E.
Okay, I will choose E to discuss. Hello.
Dr. Hatim, it is a mute. I don't know why.
Oh, yes, I'm so sorry. I was mute, exactly. What about B? Look at B.
Regarding the remodeling of the atrial, lead to uniform dilatation in the 3 dimensions.
I think it is false because the anatomy of the atrium is different.
Okay. In what way different? In what way different? You are right.
The atrium will not contract uniformly, so that the remodeling will not be uniformly.
Yeah, here the problem with this one is important, and we teach people in echo that the use of the parasternal long axis to calculate the diameter of the left atrium and judge upon the dilatation of the left atrium based on that single measurement is not true. And why it's not true? Because when the left atrium has to dilate for a reason, usually we assume that it dilates equally in the 3 dimensions. And the 3 dimensions are what? Are mediolateral, infero-superior, and antero-posterior, right? These are the 3 dimensions. And the one we measure from the parasternal long axis is the antero-posterior. For what they found is that the left atrium dilates the least in the antero-posterior dimension, simply because the left atrium in this dimension is constrained by the sternum from the anterior and the spine from the posterior, so it cannot swell in this dimension as it can in the other 2 dimensions. So usually the dilatation of the left atrium is not homogeneous in the 3 dimensions. It dilates more it dilates more mediolateral and inferior superior more than anterior posterior. Okay? And that's why measuring the LA diameter in the parasternal long axis can be so misleading as to the LA size. Okay? You get this point?
Dr. Hatim, it doesn't relate it to the atrial skeleton. I mean the part of that muscular and part of it is tendinous. Not related to that one. Just related to you mean the sternum and the spine. That's all. Yeah.
Yes. Yeah, exactly.
Okay.
Yeah. Okay.
Thank you.
And so we have eliminated so far B and D. Anything and A also. A, B, and D. Okay. Anything else to eliminate?
In the basal.
E also.
E also, huh?
Yeah.
Okay. E. Any explanation?
Yeah, because the function of leaflet, it depends on the leaflet itself, the anatomy itself, not only the annulus.
Okay.
I mean, if it is unicuspid, different from tricuspid, different like that. And it's same also affected by the annulus dynamics, if it is dilated or not.
Okay. Here طبعا الآن في physiology about the correlation, or not the correlation, the dynamics of the valve together and the relationship with the muscle and stuff like that. It seemed that our understanding of the valve motion is so simplistic, and it's actually more complex than what we thought. A tricuspid leaflet, the dynamics of the leaflet have a lot to do with the aortic root itself. And I urge you, if you are working in echo, there are so many times when the aortic valve looks so nicely normal, but there is AR. The only explanation for that is aortic root dilatation. Or aortic root is stiffening, not even dilatation. Sometimes the aortic root is not dilated, it's just stiff. So even stiffening of the aortic root will lead to dynamic problem in the tri-leaflet of the aortic valve leading to aortic regurgitation. So the dynamics of the tri-leaflet aortic valve has a lot to do with the dynamics of the aortic root. So they are taken as one unit, anatomical and functional unit. So number E is true. The function of the aortic tri-leaflet relies on the aortic root recoil and dynamics. That means C is wrong. C is that the basal myocardium, in the basal myocardium resides the densest adrenergic receptors. Remind you of Takotsubo. You know, in Takotsubo we have apical ballooning, right?
Yes.
Right? And,
yes.
and that's it. The mechanism of which is thought to be is an adrenergic surge due to psychological or physical stress. But
Yes.
why this adrenergic surge affects the apex more than the base? Because the heart histologically has more adrenergic receptors in the apex than in the base. That's why the apex is affected more during stress, during adrenergic surges than the base. Okay? So number C is wrong, and the opposite is actually true. The apex more than the base of the heart. Okay? Good. Now, which of the following causes reversed splitting of the second heart sound? Right bundle branch block, mitral regurgitation, ASD, pulmonary stenosis, and permanent pacemaker.
Right bundle branch block.
Right bundle.
Permanent pacemaker.
Okay, we start as mentioned. ASD is cause fixed splitting of the second heart sound. Pulmonary stenosis cause widening of and splitting of second heart sound.
Also right bundle branch causing widening because it makes the pulmonary valve to having more delaying. I go with the permanent pacemaker, which is left bundle branch.
You go with the B. I think RBB and ASD and pulmonary stenosis and permanent pacemaker, it will make the pulmonary area, and also pacemaker, it can lead to reverse it. It can close the pulmonary valve earlier than the aortic valve. So it's difficult. The BMR and also, yeah, permanent pacemaker, if it activates the RV earlier, yeah, it can reverse.
Because there is the left bundle branch block with permanent pacemaker.
Mr. Hatim is off or mute?
Yes, I am mute again. So good. I like this discussion. So as to the splitting of the second heart sound, we can have fixed splitting of the second heart sound, wide splitting of the second heart sound, reversed splitting of the second heart sound.
Yes.
Okay. Let's start with fixed splitting of the second heart sound. And the only example I wish you all know about is the ASD.
Yes.
Now, why ASD causes splitting of the second heart sound? Why the splitting? Because it brings more blood to the right side.
Yes,
why
is
it
pulmonary
fixed?
valve.
But why is it fixed? Fixed means it does not change with
because there is no change during respiration.
No, it is because it's a normal physiological finding. So when the second heart sound usually is later than the first. That's why the splitting usually will be the second is the delay.
Yeah, but usually physiologically, you will have a splitting of the second heart sound that increases during inspiration, because inspiration will bring more blood, so the right side will take longer time to push blood out and closes. Now in ASD, I have it fixed. It is wide but fixed. It doesn't change with respiration. So in inspiration and in expiration, it's the same widening. It doesn't change. Why is that?
Because there is an equalization of
because the flow
because the ASD leads to equalization, so it will not affected by respiration.
The shunting of the blood
Because the
keeps the
flow
pressure the same.
increases from the shunt during both inspiration and expiration.
Okay. I think you are all around the right answer. If you could see my drawing here, left atrium is this one, right atrium is here. Let's take inspiration. Okay. Inspiration. During inspiration, we will have more blood coming here, right? You agree? You agree?
Yes.
We will have more blood coming to the right atrium.
Yes.
But that high blood will increase the pressure in the right atrium, so there will be less blood coming through the hole. There will be less blood coming through the hole. Now let's go for expiration. Expiration, we will have less blood coming to the left, to the right side. Therefore, the pressure in the right side is lower, and that will enhance the flow through the ASD. So we'll have more blood through the hole. Less blood, but more blood. That's why they are equal in inspiration and expiration, because one is high, one is low, the other is one is low, the other is high. So the final result is that the blood remains stationary of fixed volume during inspiration and expiration. You get the point here?
Yes.
Very good. So the right, now we come to the wide splitting. Why it becomes wide? Anything that increases the flow to the right side or increases resistance to opening of the right side. Meaning, let's say,
Pulmonary
like what?
stenosis. Pulmonary stenosis.
Okay. Right bundle branch block. Because the right bundle branch block, the impulse reaches the right side later than it should. So it takes time. It takes longer time. So right bundle branch block leads again to wide splitting. So now the reverse splitting, meaning that the aorta closes before the pulmonary, especially during expiration, and that's why. That's why.
Mitral regard.
Mitral regard, sometimes yes, because mitral regard will take the blood flow away and the valve will close earlier. The aortic valve might close earlier. Yes. Agree?
Yes.
What else? لكن لاحظ معي في الميترال regurgitation there will be no reversal, right? Mitral regurgitation, it will not cause reversal of the second heart sound, because by reversal we mean that the aorta closes after the pulmonary, after, not before. But the physiology is that the aorta closes before.
Yes.
That's the physiology.
Yes.
Okay. So the MR actually widen the split. But tell me about a condition when the aorta closes after the pulmonary. Like what?
Left bundle branch block.
Left bundle branch block.
Yes.
And similar to left bundle is pacemaker, because pacemaker is left bundle. And what else?
Accessory pathway.
Accessory
Aortic
pathway.
stenosis.
Aortic stenosis. Because in aortic stenosis, it takes longer time to open the aortic valve.
Aortic.
Yes.
Or HOCM.
Pulmonary hypertension.
HOCM also. Yeah.
Systemic hypertension.
Huh?
Systemic hypertension also. That's not that.
Systemic hypertension, sometimes it can, yes. Okay. So these are the causes of reversed splitting of the second heart sound. Good. Now, this PW signal shows mitral stenosis, diastasis flow, pulmonary hypertension, lobster sign, restrictive pattern. If you remember from the session of diastolic function and dysfunction, something like this appearing there.
Diastolic dysfunction.
Diastolic dysfunction. Okay. Why did you say diastolic dysfunction? If I zoom in, look here, what we see is this. We have the E. That's the
Decrease
E.
in the deceleration time.
Oh,
Very
yes.
short
Yes.
deceleration time.
Very good. Yes. And that's the E, and that's the A. But between the E and A, there is a flow, right? Usually the E, it looks like this, and then the A is start. But if there is filling in the middle, that is called diastasis flow or mid-diastolic flow.
Diastasis flow.
Mid-diastolic flow can mean two things. What are they?
Can lead to. معلش دكتور حاتم عيد السؤال تاني.
يعني this mid-diastolic flow عنده two meanings.
معناها في bradycardia أو prolongation يعني.
No. It could be there is a volume overload in MR. It can happen. Also, if there is some sort of diastolic impairment, also there is diastasis.
يبقى diastolic dysfunction.
Or
right?
Or MR.
MR. I will take the first. اللي هي diastolic dysfunction. In diastolic dysfunction, why do we have mid-diastolic flow? لأنه in diastolic dysfunction, when the left atrial pressure is high, it will be high in the three phases, the early, the mid, and late. That's why here, in the mid-diastole, assumes to have equalization of pressure between the left atrium and the left ventricle, and therefore the gradient is zero, and therefore no flow. But in diastolic dysfunction, because the LA pressure is high, it will remain high in mid-diastole, and you will see a flow in mid-diastole. So diastolic flow here indicates high diastolic dysfunction, high grade of diastolic dysfunction. And it can also be seen in normal athlete young people. Okay? Why is that? لأنه الناس اليونج الأثليت بالذات they don't have high LA pressure, لكن they have a very super relaxing left ventricle. So it relaxes so well even in mid-diastole. And when it relaxes so well in mid-diastole, it maintains a gradient. And there is a mid-diastolic flow as well. So the LV is sucking everything from the left atrium because it's relaxing so well. So you can find this mid-diastolic flow in the two extremes. Very bad diastolic dysfunction and very good supernormal diastolic function. So how can you sort these two out? You know, this is normal or abnormal. By the other parameters, you look at the E prime, E over E prime, the left atrial size, LVH, and all of that, okay? لأنه نحن عرفنا في آخر session إنه diastolic function analysis is encompassing so many measures. It's not a standalone measure. There is no, sorry, there is a lot of sounds here. If I can mute. Just try to mute if you are. Okay, so what I was saying is that the diastolic function is not a matter of a single measure that will give you a final diagnosis. It's a matter of complete analysis that includes so many parameters. Mitral inflow on one side, the E and E prime on the other side, the LA size, the left ventricular hypertrophy, the clinical presentation itself, the pulmonary hypertension. So all these things together, you remember the Magnificent Four we talked about last time. So it's not about a single measure at all. It's about a composite of signs in echo, okay? Therefore, the mid-diastolic flow, by just seeing mid-diastolic flow, you cannot jump to conclusion unless you see the rest of the parameter and see whether this is super normal or super abnormal stuff, okay? Good. Now, which of the following is class 1 indication for AVR, aortic valve replacement? Asymptomatic critical AS, symptomatic severe paradoxical AS, symptomatic LV dysfunction with dobutamine echo proven severe AS, asymptomatic severe AS with rapidly progressive disease, asymptomatic severe AS going for mitral valve surgical repair. Which one is class 1 indication here?
E.
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 For any patient with moderate and severe should be for repair for other valve.
What are the other class 1 indication?
Severe symptomatic aortic stenosis.
Severe symptomatic aortic stenosis.
Severe aortic stenosis with ejection fraction less than 50%.
Very good. Yes.
Moderate to severe aortic stenosis patient going for another cardiac surgery. Severe aortic stenosis patient going for another cardiac surgery.
Okay. So we have 3 class 1 indication, right?
Yes.
3. Severe moderate going for surgery, severe symptomatic, or severe asymptomatic لكن with LV dysfunction.
Yes.
So what about symptomatic severe paradoxical AS?
(2A).
Yes, it is 2A. Okay. I know it's 2, but I don't know if it's 2AB. I don't know. Like it's class 2, not class 1. Okay. Now, symptomatic LV dysfunction, and we did the dobutamine, and we proved that it is severe aortic stenosis. The gradient went above 40 mean and all of that. So we proved this is a severe aortic stenosis. So why not this one is class 1 indication?
Because the symptoms is mainly due to LV dysfunction, not due to aortic stenosis, yes?
Maybe, and maybe because it's too late. That's why they put it class 2.
Yeah.
It's not class 1. It's class 2. Now, rapidly progressive disease is also class 2. And critical AS is also class 2.
Class 2, yes.
Okay. Good. Now, the pharmacodynamic effect of warfarin is commonly and greatly dictated by commonly and greatly. These are 2 different names or 2 different meanings. Commonly in terms of frequency and greatly in terms of power is affected by dose timing, concomitant drug use, genotype, haplotype, diet, or age.
Concomitant drug use.
I excuse anybody who choose B, because B clinically relevant, because that's what we usually see, that there is a lot of drug interaction between warfarin and so many other stuff, and dietary interaction and things like that. But this
I
not
think
the
about
right answer here.
I think about EH.
E.
Genotype and haplotype.
Genotype. Genotype. Who chose genotype?
Fikri.
Fikri, أيوة. Fikri, you chose the genotype. Can you explain it further?
يلا يا فكري.
زغت لكن ما تخلوني.
Because you are right. You are right. It's the genotype.
Yes. Yes.
It's the genotype. Yes.
It really depends on warfarin pharmacodynamics. It depends mainly genetics from yeah. That's why really it varies from person to the person.
Yes. Exactly.
Yeah, it depends on cytochrome enzymes.
That's
why it affected by the cytochrome B.
لا cytochrome ده مع الدرج صح؟ لا.
هي تحديدا يمكن اعقد لكم الامر شويه. في حاجه اسمها VKORCI and CYP2C9. These are genotypes. These are the most important determinant of warfarin dosing. And there is big variability in people in these genotypes. That's why there is big range of variability in the sensitivity of dosing in warfarin between people. عشان كده نحن مثلا بتلاقي patient تديه مثلا 5 milligram and his INR shot up to 2.5 within few days. واحد ثاني في بعض البيشنت نحن وصلنا معاهم 20 and 30 milligram.
Yes.
Okay? 20 and 30 milligram. Exactly. وفي ناس 2 milligram. يبقى ال variability في dosing depends on these genotypes. Okay? Yeah, this is important. Now, what is the pharmacodynamic effect of a drug? When I say pharmacodynamic, what does that mean? And what's the meaning of pharmacokinetic?
Kinetic, how the body acts with the drug, and the dynamic, how the drug affects the body.
Exactly. Thank you so much. So the pharmacokinetics, how the body deals with the drug. Absorption, excretion, metabolism, these are all pharmacokinetics. Pharmacodynamics is the effect of the drug on the body. The receptor attachment, the mechanism of action, and all of that, okay? Good, well done. Now, what is this?
Fibroelastoma.
Yes, this is a fibroelastoma. So you see the stalk and the shimmering edge, which means a hairy kind of a head, hairy kind of a head. When you see it by echo, you can demonstrate that as if you have a head with hair. And see here where it is, it's incarcerated into the coronary ostia, right? This is the coronary ostia. So it goes into the coronary ostium sometime, and it can lead to ischemia. Lakin more likely than this, it can lead to embolization, right? Embolization. Lakin sometimes can lead to ischemia by going into the ostium of the coronary artery, like this one here. It gets incarcerated there, and it might lead to severe ischemia sometimes, okay? And you have to excise it if there is an embolization history or if the size is more than 1, okay? If the size is more than 1 or there is embolization history, you have to excise it. That's indication for surgery. Okay, Now look at this hepatic venous Doppler tracing with respirometer. What other echo features can be elicited in this patient? Severe TR, pulmonary hypertension, LV thickness, septal shutter, precardial effusion. Yani, if anybody of you can just describe the tracing. In 3 words.
Systolic and diastolic flow.
Okay.
During systole and diastole.
How does that relate to respiration?
Systolic reverse.
Okay. And how does that relate to respiration? Look here. This is what?
Increase during
This is the
expiration.
spirometer. This is the spirometer. This is inspiration. When the spirometer goes up, this is inspiration. So this signal here is inspiratory signal.
Decreased.
Now this is expiration. When the respirometer goes low like that, this is expiration. And look how the signal is. So we have more flow during expiration than inspiration. You agree? You agree? So this is expiratory flow reversal. Increased expiratory flow reversal. Increased or enhanced or augmented or exaggerated. These are all terminologies in echo. Okay? There is physiological diastolic flow. But if it increases during expiration, that is meaningful. And that means what? When the reversal in diastole increases during expiration, that indicates constriction.
Constrictive pericardium.
Yes. Okay. So in this case, we have constriction, right? You agree?
Okay. Yes.
So which one of these?
Not severe TR.
Not severe TR. Severe TR, you will find a systolic reversal, not diastolic reversal. All what we see here are diastolic reversal. The systolic reversal is this one. I'm gonna show you here.
Okay.
This one is diastolic. If it goes this, sorry, this is systolic. If I see this systolic up here, this will be systolic reversal of severe TR. But the diastolic reversal has nothing to do with severe TR. It has something to do with constriction, restriction, diastolic dysfunction of the RV and stuff like that. Okay? So in this case, if we demonstrate that we have an increase in diastolic reversal during expiration, this is a very essential and crucial sign of constriction. So which one here expresses constriction?
D.
D. Septal shutter and septal bounce. Exactly. Okay. Type. Which of the following statement pertinent to medical ethics and conduct is false? Not true. Is false. The physician has a moral obligation to report poor and bad doctors to the concerned medical administration. You think you are going to do that?
No. No.
دول السادسة طوال احنا بنطلع منهم.
أيوة.
You never do snitch, yeah? You are not going to snitch on your colleague at all, right?
Yes.
And unfortunately, this is a moral obligation that you have failed in. It's a moral obligation, by the way.
Oh my God.
Because he is my friend, he can be my friend, but I am in a hospital serving the best interest of patient. And if I see anything that threatens the best interest of this patient or these patients, I should report that. I should report. بالذات أنا بتكلم عن bad poor doctor who is always committing mistakes after other out of carelessness and lack of punctuality and no. يعني ما حاجة بسيطة الأخطاء المعروفة لدينا، لا أكثر من كده. I know it's difficult, لكن this is moral obligation. طيب, the do not resuscitate decision should not mandate the family consent.
Yes.
يبقى DNR,
Yes.
do you have to secure the family consent for DNR?
No.
No, at all. This is
No, it's
purely
a
medical
doctor
decision.
decision.
Exactly. Physician may, in exceptional situation, have to place the interest of others above those of the patient.
No.
Yeah.
لا في exceptional أيوة. اللي
أيوة,
هو في
exceptional.
ال HIV وال
Exactly, like notification and
yes.
if he is a danger to the community,
Viable
somehow you can report him.
This is true.
Mutual decision making between the patient and the physician has to replace the paternalistic approach to decision making. Paternalistic يعني أبوي كده أنك أنت بتقرر بسوبر authority بتقرر عن البيشنت. طبعا this is no longer valid. مش كده؟ Yeah, this is wrong. Yeah, exactly.
Yes.
يعني now بقى
No paternalism.
exactly. The physician will be held accountable in the court of law if he violated the guidelines recommendation in the management and that has resulted in damage.
No.
Yeah.
If he applied the guidelines recommendation and there is a damage happened, so what's the problem?
لا بس الفيزيشن ده مشكلته he violated the guidelines.
Right.
Violated the guidelines. يعني he did not go by the guidelines and he did something different and that something different has resulted in damage. Will he be held accountable?
Yes.
Yes.
Right.
Right. So which one is false then?
The physician has moral.
B.
B. Type. Believe it or not, the false answer is E. The rest are all true.
How is that?
How is that? Type. Let's go here. Just a moment. Where is this one?
والله ethics دي نحن ما نعرف صراحة.
طيب.
نحن not applying all the ethics هنا يعني.
لا هي دي قضية شوية صعبة بقت الموضوع الميديكال ethics and their relationship to the guidelines وكده.
أيوة.
Recommendation اللي هي guidelines may not be appropriate in all circumstances. And the decision to adopt a specific recommendation should be made by the practitioner, taking into account the individual circumstances presented by each patient and available resources. The clinical guideline recommendation do not replace or remove clinical judgment or the professional care and duty necessary for each specific patient case. Therapeutic option should be discussed with a patient on a case-to-case basis as necessary. طيب. القضية دي أنا بقولها لكم ليش؟ لأنه I have been involved in so many legal cases. But I know exactly how the issues go first hand. أولاً إذا واحد فيكم مثلا جاهو patient with non-STEMI. Okay, non-STEMI is acute coronary syndrome. يعني according to the guidelines, non-STEMI goes for coronary. Now he sat back and relaxed and thought of this patient. Like this patient had renal impairment of moderate degree. He sustained the stroke 3 months ago, and he is into forgetfulness and stuff like that, early dementia or whatever. So he decided that the best way forward is to go medical therapy. He went medical therapy. Next morning or after 2 days, patient developed VTAC and he died. Family sued the physician. How come you did not do PCR? طيب جاء عند القاضي. Did this patient, this physician violate the guidelines? Yes. Guidelines بتقول acute coronary syndrome go for PCR. لكن ال guidelines are generalization. They talk about acute coronary syndrome as acute coronary syndrome. They don't know exactly about the patient in detail. بالتالي they remain generalization. ولذلك القاضي will not use the guidelines as a legal manifesto على الإطلاق. يعني ما في يوم من الأيام أنت مثلا the same patient البيشنت ده نفسه لو أنت عملت له كاث وحصل له renal failure because of contrast nephropathy ومشى اشتكاك تمام. هنا أنت you have gone by the guidelines لكن you have created damage. ما حتيجي تقول للقاضي أنا والله I just stick to the guidelines or I am so clean. No, guidelines has no place in the court of law. What does the court of law, okay, go by these cases? بيجيب expert witness. بمعنى يقوموا يجيبوا مثلا cardiologist. طيب يقولوا للكارديولوجيست أهو ده الحالة كده. What do you think? Are you gonna agree with this track of management? Do you think that is right if you were in this physician's shoes? Are you gonna do the same or this is different or stuff like that? وما شرط يجيبوا one expert witness. Sometimes بيجيبوا panel of expert witness عشان هم يحددوا إنه لأنه الguidelines are generalization والكيس دي فيها details كثيرة غير موجودة في الguidelines. بالتالي we need a help from a cardiologist with similar experience and similar exposure to decide whether this line of management as taken by this physician is right or wrong. Okay? هنا الاكسبيرت ويتنس الشهاده بتاعته او التستيموني حقته هي اللي بتحدد مسار القضيه بشكل كامل. It's not the guidelines at all. There is no discussion of guidelines in the court of law whatsoever. Not in America, not in USA, not in Saudi Arabia, no at all. Okay? كويس. ولذلك هنا the physician will be held accountable if he violated the guidelines and that resulted in damage? No, unless the expert witness panel condemn this line of management. قالوا لا غلط كده yes خلاص تورط الفيزيشن لكن otherwise no. Okay? Now guidelines. Which one best describe the exact value and use of guidelines in medical practice? Why are we using guidelines? To dictate the practice through unbreachable rules.
No.
Of course, no. To provide legal coverage for physician?
No. Sure, no.
No? خلاص قلنا no تماما.
أيوة.
To serve the best interest of the patient?
Yes.
To benchmark the clinical practice?
No.
To standardize and legitimize the clinical practice.
دي كويسة.
طيب دي كويسة لكن فيها مشكلة واحدة اللي هي to standardize yes لكن legitimize ما معناتها to make it legal. Again we are in legal. هل ال guidelines are legal? No.
No.
يبقى بالتالي E is wrong. E is wrong, C is wrong, B is wrong. So we are between C and D.
C.
C.
The best interest of the patient.
Serve the interest of the patient, yes.
Right. I tell you something. Anna, one time I was with a task force of the guidelines of atrial fibrillation in Europe. Okay. And I have one or two of them, and we had a side discussion about how they manufacture the guidelines. Because there was a talk about atrial fibrillation, the best management of atrial fibrillation is ablation. Okay. Now, when they put ablation in the guidelines, they put it as class 2, and after you exhaust medical therapy and do this and that. So if it's the best interest of the patient, why it's not class 1? They say because, in the guidelines, you don't consider the best for the patient. You have to include حاجات تانية. You have to include the feasibility of doing this worldwide. You have to include the experience of physician worldwide. You have to include the cost of this procedure worldwide. So it's not about the best interest of patient on table. There are other factors on table too. The cost, the ubiquity, the feasibility, the experience, the armamentarium of cardiac center worldwide. So there are so many things. يعني الآن لما نقول this is class 1 معناته it's a standard procedure. معناته we assume that this is available everywhere في العالم في cardiac center and they have to do it. لكن we know that في cardiac centers كثيرة they are not capable of doing ablation. بالتالي if you make it class 1 indication بتبقى هنا في مشكلة beside الcost beside الحاجات الثانية الكثيرة. يبقى ال guidelines are not serving the best interest of the patient. أي نعم the best interest of the patient is on the table لكن مع factors ثانية وبالتالي مرات بيضعف وجوده among الفاكتورز الثانية. ولذلك in the guidelines دائما is if you are patient enough and you went down at the bottom في disclaimer في أي guideline في disclaimer معناته إخلاء مسؤولية. بيكونوا كاتبين فيها شوفوا الجايدلاينز دي generalization والله ونحن ما قاصدين إنه تكون ملزمة لكم. أوكي. وكل واحد لازم يتعلم how to evaluate a patient individually and deal with him according to the clinical judgment and clinical according to the experience of the center he is in. يعني الآن أنا مثلا I belong to Prince Sultan Cardiac Center. I know the experience of the EP lab is so huge and vast and they can do ablation for all patients with AF. بالتالي we are going to do ablation for AF. لأنه I know هنا I am individualizing the patient case according to the patient case, according to my clinical judgment, and according to the experience of the center. Okay? كل الحاجات دي تجمع مع بعض عشان تقرر عن البيشنت. يبقى حاجة فيها realities كثيرة ما just the patient alone. Okay? يبقى بالتالي it's not necessarily serving the best interest of the patient. It's just to benchmark the clinical practice. Benchmark يعني to put it in the context of evidence-based medicine and standardize it. عشان نكون كل الphysician they are talking the same language and stemming from the same evidence. That's it. These are the guidelines. Okay. Good. What is this? This is the right atrium. What is this? Any guess? Yes, Yes, this is a Chiari network. You know the Chiari network?
Yes.
Yeah, Chiari network is an embryonic remnant. Usually, it goes so small and not appreciated in adult life, like in some time it remains and it goes as big as this one. And we so many times see Chiari networks or a prominent Eustachian valve, both of which are normal variant and they have no clinical implication, illa sometimes مع intervention when they go to the right side of the heart, بالذات ناس EP sometimes, they go in the right atrium and they need to negotiate the coronary sinus. فيتخيل انه عندهم 3 catheters in the right atrium، ممكن يحصل شنو في وجود الكياري نتورك؟ They can get trapped in this network and the catheter will be trapped and entangled into the network and they cannot negotiate and sometimes they cannot even take it back. Okay, لذلك ناس EP تحديدا if you see Chiari network you have to report it لناس EP. Okay, it's important. يعني مرات you don't have to، لكن لو الpatient going for EP procedure I think you have to alert the cardiologist in the EP lab إنه في Chiari network to be cautious in manipulating the catheters. Okay.
Yes.
Okay. So I need somebody to read this.
Yes.
Okay.
DMV 1B are important prognostic markers. Which of the following statement is not true at their dynamics and utility? A, high level in acute coronary syndrome is prognostic. B, higher level is expected in HFrEF than HFpEF. C, higher level is expected in heart failure due to constrictive pericarditis and constrictive pericarditis. مش حاجة واحدة. طيب D, BMB trial has proven their utility to distinguish between cardiac dyspnea versus non-cardiac dyspnea. And E, sacubitril decrease the catabolism of BMB.
Good, thank you. طيب, just a small correction to number C. Number C reads as follows. Higher level is expected in heart failure due to restrictive cardiomyopathy than constrictive pericarditis. Higher level is expected in heart failure due to constrictive pericarditis than restrictive cardiomyopathy.
Okay.
Okay, so I'm gonna change this one. This one. Restrictive cardiomyopathy. Okay, so what do you think? So higher level in acute coronary syndrome is prognostic?
No.
Is it prognostic?
No.
Yeah, true.
No, it is wrong.
True.
Yes.
True and wrong.
True.
True.
Oh,
True, because if
yeah.
there is if the BMB high indicate poor prognosis after acute
Exactly.
coronary.
Exactly. So high level معناتها is prognostic. Exactly. Higher level is expected in HFrEF than HFpEF.
It is wrong.
I don't
False.
think so. It is wrong.
False.
طيب, here BMB and pro-BMB comes from where? They come from the ventricle under stretch. So the more stretch, the more of pro-BMB. طيب, if there is more stretch in HFrEF or HFpEF?
In HFpEF.
In HFpEF. يعني usually الHFrEF is low ejection fraction, dilated LV, and this dilated LV is the stretch. Now in HFpEF, you usually have LVH and small cavity and not much of a stretch. لذلك الHFrEF, usually in HFrEF, we find pro-BMB in thousands, like 10, 20, 30, 40. يعني أنا recently I have seen a patient of 160,000. لكن in HFpEF, it's elevated in few thousands, 1,000, 2,000, 3,000, stuff like that. So I think higher level is expected in HFrEF than HFpEF is right. higher level is expected in heart failure due to constriction than restriction?
False.
No.
False.
False.
The stretching of myocardium is less in restrictive.
The stretching is less where?
Constriction less.
Constrictive.
In constriction is less, right?
Yes.
Yes.
Okay, good. لأنه in constrictive pericarditis, the heart cannot stretch because of the tough pericardium around it. لكن in restrictive cardiomyopathy, it can stretch لأنه ما في limitation from outside. بالتالي expectedly pro-PNP and PNP will be higher in restrictive cardiomyopathy than constrictive cardiomyopathy.
Yes.
Good. طيب. BNP trial. BNP trial is the very initial trial that studied the utility of BNP. And BNP trial stands for breathing not properly trial. Has proven their utility to distinguish between cardiac dyspnea versus non-cardiac dyspnea.
True.
Yeah, exactly true. Sacubitril decreases the catabolism of PNP.
No.
True.
False.
No,
Yes, true.
enhances the catabolism because that's the pro-BNP is high after starting medication.
True.
Increase.
Increases
the
what?
pro-BNP is increase after starting the medication.
Exactly. You are right. So sacubitril increases the level of PNP through decreasing the catabolism of PNP.
So this is true.
Yes. We have now the ARNI class. ARNI stands for angiotensin receptor neprilysin inhibitor. Neprilysin is sacubitril. Sacubitril is neprilysin inhibitor. And what neprilysin does? Neprilysin does what? It catabolizes the PNP. So if I inhibit the catabolizer, I'm increasing the level of PNP. So sacubitril is neprilysin inhibitor, and neprilysin catabolizes the PNP. Okay? So sacubitril increases the level of PNP through decreasing the catabolism of PNP. Good?
Yes.
Okay. So I think I shouldn't tell you longer because that will be boring. We still have a lot to go, like we can carry on probably next week.